This is Dr. Kathryn Dao reporting for Room Now, and you wouldn't believe it. I have the famous Dr. Al Kim here. And, he's an incredible researcher, a friend, and he's done amazing work with COVID, lupus outcomes, as well as basic science. Welcome, Al.
Thank you so much, Kathryn, for the invite and I look forward to the discussion.
Oh, absolutely. I'm going to pick your brain. So first of all, your name is everywhere. Like on almost every other abstract I'm coming across, I see Al Kim, Al Kim. Could you go ahead and summarize basically all the exciting work here at ACR that you all are presenting and with your group?
Yeah, so specifically with our kind of internal group at WashU and at UCSF, we've done the COVARIPAD study, or continue to do the COVARIPAD study, which is COVID-19 vaccine responses in patients with autoimmune disease, and the observational longitudinal study examining both acute and long-term immune responses and also reactogenicity along with patient-reported outcomes following COVID vaccination in the immunosuppressed with autoimmune diseases. So there's going to be a lot of both descriptive data, but also mechanistic data downstream once we find some very interesting relationships that have yet been uncovered in terms of the relationship between immunosuppression and vaccination responses.
Yeah, no, it's fascinating, all the data that you presented. And the one that caught me by surprise was the fact that patients on TNF inhibitors and, how like in vitro, albeit it's in vitro studies, but they had poor neutralization to the Delta variant. Could you speak a little bit more about that?
Yeah, so there is some background to this. Mice that are deficient in TNF alpha do not mount germinal center responses. I'm going to get to why germinal center responses are important in a second. But in our study, we did see that people on TNF monotherapy, so they were not on concomitant DMARD or steroid or antimalarial use, had a greater proportion of patients that had poor neutralization of Delta variant compared to other immunosuppressives and also the immunocompetent group. And by the time we went about 5 to 6 months out from their final vaccination, the initial series of mRNA vaccination, a small sample size, now it's about 5 people, none of them could neutralize Delta. Okay, so let's go back to the Journal Center. So our co-senior author and very close colleague, Ali El-Abedi, who is an exceptional B-cell biologist, has published in Nature a couple papers revealing the role of memory B cells as really blossoming antibody responses in germinal centers. So what happens when you first get immunized, like the first introduction to antigen, the germinal center in the ipsilateral arm that you get the injection. So if I get my vaccination, my left deltoid, it'll be my left axillary lymph node. That lymph node actually harbors almost all of the vaccine responses. And what I mean by vaccine responses are these germinal center responses. These germinal center responses, if you go back, this can cause some post-traumatic for some of your listeners here. They help generate these high affinity B cell receptors. They eventually will grow up and produce antibodies. On top of that, though, part of that affinity process, there's another process called somatic hypermutation. That process, which increases affinity, also increases antibody diversity. Now go back to the TNF knockout mice that don't have germinal centers. So theoretically, if you give a vaccine to, say, TNF knockout mice, or even people that are having low levels of TNF because they're on inhibitors, you could potentially attenuate or stop the germinal center process. And that's important because we all got vaccinated against common variant. Yet most of the immunocompetent people are able to perfectly defend themselves against Delta variant. How? It's because of the antibody blossoming response in the germinal center. So when you block TNF, there's a theoretical risk here that you may also then blunt these antibody blossoming responses. And maybe that's what we're seeing. Now, having said that, kind of the nitty gritty behind all of this too, is that remember that knockout mice are deficient of that protein since neonatal life. Whereas in the real world, adults that are started on TNF inhibitors for say RA, they've had it for a long time. Then there's a partial reduction through medication. How those two correlate with one another is a little bit unclear to us. So Michael Diamond, who's one of the immunovirologists here at WashU, is starting some mouse studies to better examine this relationship, both with SARS-CoV-2 vaccination, but also influenza vaccination to see how broad this phenomenon could be.
That's incredible. There's some parts of the world where they're doing 3 doses, and then 6 months later, they're going to do the booster.
Mm-hmm.
So that's a lot of vaccine, right? But
it is.
But maybe, it might be needed for patients, who have been on rituximab or mycophenolate or some of the other things. What do you think?
Yeah, so I think this is a really important point. So again, Ali El Abedi just had a preprint drop 5 days ago on bioRxiv, showing that similar to influenza vaccination, that germinal center responses in humans, so that he actually got lymph node tissue, and I was one of his subjects, up to 6 months post-vaccination, germinal center responses were still ongoing in all of these subjects. Right. Again, this is without any additional introduction of antigen. Now, think of a particular scenario, say anti-TNF, where you are blunting that response, right? If you get a booster, you could regenerate that response and get the antibody blossoming that you should have had in the first place. Now, the preprint that has the delta neutralization data doesn't have data that was added into our revision for this paper with Mike Diamond, but of the 5 people that had no delta responses, all of them got boosted, and 1 month afterwards, they all generated delta responses. So this tells me, first of all, that even and none of them held their TNF. So this tells me, first of all, that the germinal center response is potentially restartable, even in the context of TNF inhibition. So this opens up the question about holding medicines, which is a completely different topic. But more importantly, from the immunologic point of view, memory B cells are absolutely critical for that antibody blossoming response. They are being generated in these TNF inhibitors. So this now is opening up another question about antibody function in TNF inhibitor people, and whether or not that's also dysregulated or dysfunctional. But to answer your question more directly, I think the more doses your body sees, more safely with vaccination than natural infection, the more you're able to blossom your antibody response.
Right. We're getting boosted a little bit every day. Had we been at ACR in person, we might be boosted a little more.
Oh, yeah, right, exactly.
All right. So lupus has been so dear to your heart. I've listened to you lecture. Tell me, what do you think it's going to be the biggest impact in regards to the lupus world? What have you seen at ACR or even outside of ACR that you think is going to be the next big thing?
Yeah, so macro is clearly the explosion of therapeutics, right, that have been or will be FDA approved. This is giving us a range of choices that is foreign to lupologists. It harkens back to our training when we were able to have many options for RA patients, right? So it's going to be interesting to see how the ecosystem decides how to prioritize things. I think a lot of lupus physicians will obviously clearly engage with shared decision making. The first question I ask is whether or not they want an injectable or a pill, right? And what's interesting is there's pretty strong opinions, pretty much 50-50. There are needle averse people, and then there are people that say there's no way I'm ever going to take pills because I already take 12 or 16 a day. I'm going to go ahead and get an injection. So that ends up simplifying that narrative with existing therapeutics. I think in the future, there's going to be, I think the AMP effort continues to pump out just really interesting observations. It's so hard to get human tissue and do detailed phenotypic analyses, immunologic analyses on them, but obviously they've, through the expertise of their large team, they have the ability to be able to get high quality data that will likely lead to meaningful therapeutics downstream, whether that's going to be, again, interferon based, JAK based, again, using existing therapeutics and repurposing them, or will it be newer things? Kind of proteasome is kind of old, but it's kind of new. There's that topoisomerase 1 inhibitor, complement is going to be emerging as a general theme in terms of therapeutics in the future. There are numerous other bispecific molecule antibodies that are going to be targeting, multiple cytokines or a cell type with a cytokine or 2 receptors on a cell type, like on a B cell. I think the other one that I'm really interested to see would be inhibitors that block the follicular helper follicular helper T cell and B cell interaction within germinal centers. I think, or actually more specifically, potentially extrafollicular pathways. So B cells appear to be activated through two different mechanisms, and Inaki-sense has nicely shown these extrafollicular B cell pathways are main source of autoantibodies, both in lupus, but also COVID-19. So how do we specifically target that? That doesn't necessarily disrupt the germinal center itself, would be very lucrative. I think that's an interesting pathway to pursue. So, I would say people like obviously Peggy Crow, Michelle Kallenberg can speak much more about the specifics of interferon therapies, which I think is another important field that continues to be dissected out. But, to me and my own biases, those are the interesting things.
Oh, absolutely. And, a lot of ACR has been dedicated to preclinical autoimmunity too, which, they're looking at targeting pathways before an autoimmune disease can even start. Your thoughts on this?
I think these are admirable studies. The hardest part that it's going to be difficult to, kind of churn out is, are you looking at people at risk, or are you looking at the, say, preclinical group, right? Because and are there differences between the two? We only can measure what we can measure, and it's not like we get weekly blood draws from healthy subjects who are, say, autoantibody positive, over time. So I think this is going to be the one, criticism that you can't really address right now in those type of studies. But at the end of the day, even if you're preclinical, if the introduction of the therapeutic is modest in terms of risk, let's say hydroxychloroquine, number needed to treat to prevent versus number needed to harm, it seems like it would be in the favor in number needed to treat, right? It seems like that, right? So anyway, I think I can't even imagine myself engaging in that type of research, because the logistics and trying to kind of work out how you're going to find these people, define them, is overwhelming to me. So I really give these investigators a ton of credit for thinking about how to best address this. Of course, David Karp with lupus, and then Kevin Dean, Jeff Sparks with RA, and numerous other efforts. I mean, these are just, I'm just floored that these studies are ongoing.
Yeah, I really appreciate that you allow me to pick your brain, and I wish I had more time to pick it some more. But there is one burning question that all our viewers want to know. You ready?
Oh, yeah. Do I have a choice?
All right. What's your skincare regimen? Oh my God. It's like everybody who watches you, and we're like, holy cow. And it's not a filter, because I've seen you in person. You got great skin.
I appreciate it. The skincare regimen is largely genetic and epigenetic, I think. I wash my face. I don't even really know which soap I use. I use a Jergens body lotion for my face, because that's all I got, on my sink. I'm not picky. I just, you got to make your skin tough in order for it to, absorb the environmental insults around you.
There you have it, viewers. I really appreciate you, Al. I always love interviewing you. And you know what? We're going to talk again. Hope to see you at the next ACR meeting.
All right, take care. Thank you.
This is Dr. Kathryn Dao reporting for Room Now. Follow me on Twitter at KDao2011. I'm also known as the Dao Index.